Namaste and welcome back. So I've gotten some great feedback and some requests on my YouTube channel, and keeping those in mind, I'm going to start the new topic on facial nerve. It's anatomy, clinical science, and ultimately facial nerve palsy and the surgeries that are covered for it in plastic surgery. So a short video first on the facial nerve anatomy. I know it's quite confusing and it becomes overwhelming initially when we see it. So I'm going to try and break it down into a very simple way. So we are going to study the basic important points that are required from the surgical point of view as well. So we all know the facial nerve is the cranial nerve number 7. Now this is a very special, highly skilled nerve, you can say, because it has got its motor supply, sensory supply, where it also has a specialized sensory function, as well as the parasympathetic innervation that it gives. Now, if you have seen my previous video on the pharyngeal arches, you know that this is the nerve of the second pharyngeal arch. Now, the facial nerve course is like all the nerves divided into an intracranial and extracranial course. So here is where I'm going to break it down. We are going to first talk about the intracranial course of this nerve, where it gives off 3 main branches and it forms a ganglion. Okay, so the important points that you need to consider when you are looking at the intracranial course of this nerve is that it begins from the region of the pons, and then it traverses through the petrous part of the temporal bone, after which it will form the geniculate ganglia and it forms 2 genu, that is known as the bends or the curves that you see in its course, and it traverses through the facial canal in the form of a Z shape. So this is the Z or the Z shape that it forms. So like I said, this is a highly specialized mixed nerve, so it has a motor nucleus as well as a sensory one. Both of them combine and they form the intracranial part of the facial nerve. Now firstly, when it's inside, that is when it's intracranial, it crosses through the internal acoustic meatus, the IAM, after which it forms the geniculate ganglia, and when it's traversing the facial canal, it's going to give 3 main branches. That's why I have mentioned 3 plus 0 here to show 3 branches, and O or 0 which is showing the ganglion. Now these 3 are important to know also when you are going to have to differentiate between the upper motor, lower motor neuron lesions, exactly where the facial nerve has been damaged, whether it is on a terminal branch or whether an intracranial involvement is seen as well. So the first branch, it's easy to remember, it's the greater petrosal. So because it's a greater nerve, it's the first nerve. So this branch is going to supply the lacrimal glands, and it's going to help in the tear formation. Now this is part of the parasympathetic innervation that is provided by this nerve. Now S for stapedius and S for second. So the second branch is the nerve to the stapedius, which is involved in the stapedial reflex. That is the reflex which is seen in response to sudden loud noises. Now T for tympani and T for third. That is the chorda tympani, which is a specialized innervation that is for the taste sensation, that is in the anterior 2/3 of the tongue. Now don't get confused with the name tympani. This is not in relation to the tympanic membrane or to the ear. This T tympani is for T tongue. Now as you progress further, it will come in its extracranial course. So the demarcation that helps you understand where it is becoming extracranial is through the SMF, that is the stylomastoid foramen. Through this foramen, the nerve is going to exit the temporal bone and its extracranial course will begin. Now again, we are all very familiar with the terminal 5 branches of the facial nerve, but before that also you should remember that there are 3 other branches that are given by the facial nerve, again in its extracranial course. So like I had mentioned at the beginning, that the extracranial course has 5 plus 3 branches. Now these are all motor branches. The first one is the posterior auricular nerve, which gives the motor innervation to certain muscles around the ear. Then there is the nerve to the digastric, and then there's the nerve to the stylohyoid. So in the description of the pharyngeal arches, these muscles have been described, these nerve innervations have been described, which is given off by the facial nerve. Finally, as we progress further, we are going to see the terminal branches, that are in relation to the facial muscles and that are in relation to the parotid gland. So this is the basic understanding of the intracranial course and the other 3 branches of the extracranial course. So now let's see the extracranial course that we are all familiar with, which is the 5 main branches, which is also known as the pes anserinus, which means it looks like a goose foot. So we have a mnemonic also, or you can just remember the initials, that is with TZBMMC. So once the nerve exits the stylomastoid foramen, it is going to traverse between the superficial and deep lobes of the parotid gland, which is known as Patty's facio-venous plane, where it traverses along with the facial vein. Now there are main 2 trunks. One is the temporozygomatic and the other is the buccal mandibular trunk. So the temporal branch and the zygomatic branch supply the upper half, and then we have the middle and the lower half. So we have the buccal branch, marginal mandibular and the cervical branch. Now there are a lot of names of so many facial muscles, so I've just written the initials here. So the temporal branch is mainly going to supply the frontalis, the orbicularis oculi and the corrugator supercilii. The zygomatic branch will also supply the orbicularis oculi. Similarly, there is always some amount of innervation overlap between the branches. So the buccal branch, which is supplying the orbicularis oris, the buccinator and the zygomaticus. Some innervation may also come from the zygomatic branch. The buccal branch has a lot of terminal branches. The marginal mandibular one we all know is very important, especially from the surgical point of view, because it is a nerve that is quite commonly injured in cases of dissection in the submandibular region. So this supplies the mentalis muscle, the depressor labii inferioris and the Dow muscle, that is the depressor anguli oris, which you will see its importance when we study about the facial palsy and the muscles that it affects in the lower half. And finally the cervical branches that supply the platysma. Now there can be a significant overlap between certain terminal branches, but these are the main branches and the trunks and the divisions of the facial nerve that you must know. So this is the overview of the extracranial as well as the intracranial course of the facial nerve. I hope it is simplified now, and remembering these points, we will take it forward and we will see how it is important and related to the next topics.